Well, thank you for participating in the poll. This is so nice to see who's in the room. I would like to turn it over now to both Daisy and Claire to provide some of their background information for the project that they've embarked upon and why they do the work that they do. Thank you both.
All right. Hello, everyone. My name is Daisy Singla, and I am very pleased to be here today. Thank you so much, Karen, for having us. This is certainly a unique opportunity to present to all of you in this type of a forum. So bear with me as I present on Zoom. I wish we could meet in person. I do hope that we meet in person in due course. I'm here to talk about my journey alongside my colleague, my cherished colleague, Claire, who serves as a stakeholder on our larger project called Summit. And I will speak about Summit, but before I speak about Summit, I think it's worthwhile to provide you with an introduction. So I am a Canadian, and my parents were born in India. They came here back in the 70s. And I was born and raised in Canada. I spent a lot of the last decade in low and middle income countries. And I moved back to North America, basically to get a job and to pursue a career and a passion in maternal mental health. So as Karen had mentioned, I am a clinician scientist in the Department of Psychiatry, and I'm a clinical psychologist as well as a global health researcher. And before I get to global health research, some of you may be familiar with global health as a discipline, but I do want to mention that. The thing that really inspires me is maternal mental health. I've been working on this topic, believe it or not, for the last 15 years. And one thing's for sure is that women across the world are not getting the treatments that we know that work, including psychological treatments, which are recommended as the first line of treatment to address the significant burden of depression, anxiety, and stress-related disorders worldwide. And they remain inaccessible for the wide majority of people in the world, including perinatal populations in Canada. So that is the driver behind what I'm doing, but I'll try to describe this in so much more detail. So high-income countries such as Canada, 1 in 5 women may have access to minimally adequate treatments, whereas 1 in 20 women in low and middle income countries, such as places that I've worked in India, Bangladesh, Pakistan, and many countries across Eastern Africa, the rates are a little bit lower. Regardless, in my opinion, this is not justifiable. And so I've devoted my life to addressing the access issue that we know is prominent worldwide. I don't think this is news to probably most of this group to say that perinatal depression and anxiety affects 1 in every 5 women. In fact, some may argue that this is an underestimate, and that most pregnant women, as well as postpartum women, would prefer to engage in individual psychotherapy. However, as I mentioned before, the wide majority do not have access to these therapies. And this is just a few of the common barriers that were reported in some of the populations that we had interviewed across Toronto, Chapel Hill, and Chicago as primary barriers to actually accessing psychological treatments. Again, this is probably no surprise to this group here, but cost often comes as the first. Access to specialist care. There simply are not enough specialists to provide access to for women who experience depression and anxiety. Navigating the healthcare system, whether you're in Canada or the US or somewhere where a fragmented healthcare system exists, is an issue worldwide. There is no perfect healthcare system, and we encounter this problem in Canada as well. Transportation and childcare are frequently things that we hear from perinatal women across the board. And this was obvious, these barriers were commonly reported pre-pandemic, and I'll get to telemedicine interventions in a moment. So one solution that I've explored among many colleagues around the world have explored is the idea of training non-mental health specialists to deliver psychological treatments. there is a huge and growing evidence base demonstrating that non-specialist providers can effectively deliver manualized treatments for common mental disorders in developing countries. And what do I mean by a non-mental health specialist? Well, basically, this is anyone who provides mental health care without formal training or who has a specialized degree. So neither Karen or myself would fall into the category of non-mental health specialist. But we know that this works, and this includes health volunteers, peers, community health workers, teachers, nurses, and the list goes on, and it really depends on the context that you're in. So in some of the studies that I've worked in, for example, a recent study in India and Pakistan for perinatal depression, we trained peers because that was the group of individuals that was most preferred by the community and by relevant stakeholders. They were the nominated group to target issues of maternal mental health. Whereas a non-mental health specialist here in North America, it may be more appropriate to train a nurse or a midwife. And that's exactly what we're doing in the study that I'll be describing called Summit in a few slides. I want to introduce the concept of global mental health for those of you who may not be as familiar with this discipline. And this has really shaped me as an individual, myself as a researcher, and really all of what I do. So global mental health is more formally defined as the discipline of research and practice that places a priority on improving mental health and achieving equity for all people worldwide. And equity is really the driving factor here. And it's for that reason that stakeholders play such a critical role in everything that we do. And it was no surprise to involve stakeholders in our current study, because without stakeholders, we cannot do this research. I was so pleased actually when PCORI had asked me to put together a plan to involve stakeholders and a diverse group of stakeholders, because I can't imagine people doing this research without it. So in my mind, I would say that there's three key principles to global health, and that to this patient-centered discipline, and that involves shared decision-making, empowering women and communities, and a foundation of stakeholders. And I've had the good fortune of working with many NGOs across the world, but one of the ones that I treasure the most is an NGO called Singla. They're located in Goa, in India. And I've learned a lot of what I've learned in terms of stakeholder engagement through my work with this NGO. For example, the intervention that I mentioned in India and Pakistan, where peers were the preferred individual to deliver this manualized treatment for perinatal depression, was something that we revealed in this work, working with Singla. And effectively, this was published in a paper in Journal of Affective Disorders, if you're interested. And one of our stakeholders had said that we would like someone like us to deliver mental health care in these two very diverse contexts of semi-urban Goa and rural Rawalpindi, Pakistan. But I want to hone in on not just global mental health as something that's abroad, but global mental health as something that's local. And this is something that I've spent the last few years really emphasizing. So non-mental health specialists have so frequently people have thought of this as something that's being done abroad. But we know that this is something that is being implemented in North America and in many high-income countries, as indicated by a recent review that we conducted on just perinatal mental health. So there is a huge and growing evidence base to demonstrate that not only are non-mental health specialists delivering psychological treatments in high-income countries, but indeed they are effective. And like I said, in the studies that we have identified, the majority came from Australia, the US, the UK, and Canada. And the majority involved training midwives and nurses. And when I say midwives and nurses, I'm referring to non-psychiatric nurses involved in this process. Similarly, there is a split between delivering psychosocial therapies and psychological treatments. The wide majority have been tested and evaluated through a randomized control trial, have been delivered face-to-face. And the main reason for why this particular cadre of non-specialist provider was selected or at least according to the authors, was because they reflected the existing healthcare and community setting. And I'll get to that in a moment. I want to speak a little bit about telemedicine, which does not seem as innovative now, with everyone, including ourselves at the present moment, using Zoom. But at the time, when we were developing our idea of Summit, which is the name of our trial, and I'll come back to, basically we realized that there was huge potential in telemedicine, particularly for perinatal populations, given all the challenges there are in actually receiving and accessing in-person sessions, and that there was a lot of potential to potentially test this as it relates to in-person sessions. And so I could speak about my journey for quite a while, but basically it gave me a lot of time to think. I wanted to think about how could these lessons that we've implemented successfully abroad be implemented in a high-income country context like Canada and the US. How could we use and improve accessibility to evidence-based psychological treatments that we know that are effective and preferred by perinatal women? Who would deliver these treatments, and where would they best be delivered? So I spent a few months of my first job putting together an LOI, letter of interest, to PCORI, to exactly the funding schemes that Courtney had mentioned, the clinical effectiveness research trials. And the first time I put it in, I did not involve any US sites. But the second time we put it in, we did, and we were successful. And that was the birth of Summit. So I'm going to spend the next little bit talking about Summit. So Summit stands for Scaling Up Maternal Mental Health Care by Increasing Access to Treatment. And this is funded by PCORI, and you heard a little bit about PCORI from Courtney during the introduction. And so I'm not going to go over that. But one thing that I really appreciated about PCORI, or actually two things, was an emphasis on focusing on improving the health and well-being of patients and their families, and the expectation that you involve stakeholders. This is an expectation and something that's not negotiable. And I just thought that this was very forward-thinking for a funder to emphasize in a way that they were very serious about. And so, like I said, we were funded by the Clinical Pragmatic Effectiveness, the CER scheme, which really focuses on real-world settings and sustainability. So we got the good news in December 2018, and our study officially kicked off in June 2019. And I'm proud to say that the study has continued despite COVID, and we've continued successfully in terms of the study that I'm about to describe to you. So I hadn't realized that there are many trials called Summit. I thought we were being so innovative at the time, but we are yet another trial that is called Summit, and I think that this title is quite appropriate for reasons that I hope will become clear as I describe our study. So a bit of background on our study. We are a huge team, and I'm proud to say that we have stakeholders across the board to represent our study and to inform our study, both in terms with regards to various aspects of where we're at. The study is being implemented in 3 cities, Toronto, Chapel Hill, and Chicago, and across 5 sites. And to date, from what I know, or from what I've seen, we will be the largest psychotherapy trial for perinatal populations. We are 5 PIs representing 5 recruitment sites. So I work closely alongside my co-PI, Samantha Meltzer-Brody at the University of North Carolina, as well as Richard Silver, who's an obstetrician. Samantha Meltzer-Brody, as some of you may know, is a perinatal psychiatrist. Simone Bigot is also a perinatal psychiatrist, and Cindy Lee Dennis is a nurse by training and has a PhD in epidemiology. So it is an extremely interdisciplinary group that represents Summit. And this is just a few of our team members, including Claire on the far left-hand side. who represent our project. But as I said before, we are a large and growing team, and this picture unfortunately doesn't represent everyone in the group, but hopefully one day we will all be together. So the main questions of our study is to examine whether a brief behavioral activation-based psychotherapy delivered through telemedicine is as effective as the same in-person treatment. We also want to know whether non-specialist providers, in our case, nurses and midwives, can deliver this treatment as effectively as specialists. So I'm not too sure how many researchers are on the call, but this is a non-inferiority design, which basically examines relative efficacy in these two groups. There's a number of secondary questions that we're asking, including examining how can we basically make this as optimal as possible by examining the underlying processes related to delivery and scalability. And I'm happy to go into some of those more detail. I'm happy to go into details related to that during the Q&A. So effectively, women who are recruited to the study, and I'll get to eligibility criteria in a moment, are randomized to one of 4 arms. And so that would be telemedicine specialist, telemedicine non-specialist, in-person specialist, and in-person non-specialist. And everyone gets the same treatment. Everyone gets the same 6 to 8 session treatment. And it's delivered, as I said, in 3 cities, or what we call hubs, or 5 sites, across 5 sites. Our inclusion-exclusion criteria, in my opinion, as a researcher, is pretty wide. We want to try to, we have a huge sample of 1,368 women, half of which we anticipate to come from Canada, and half of which we anticipate to come from the US. But the reason why we have this exclusion criteria here is because behavioral activation, or the treatment that we're using, is not suitable for things like psychosis or mania, or for perinatal loss. And so it was very important for the funder to implement a treatment that has been shown to be effective and appropriate for who we were trying to target. And so we're recruiting adult women during both who are pregnant or postpartum, and we're also recruiting women who speak English in our Canadian context or English and Spanish in our US context. You might be asking why behavioral activation, and I could probably speak a lot about behavioral activation, but effectively it's a 6 to 8 session treatment. It's brief. It's known to have a strong evidence base. It's as effective as longer courses of treatment, including cognitive behavioral therapy, as well as antidepressants. It's effective for our key population, which is target disorders, perinatal depression, and anxiety. And possibly most importantly, it's easy to learn, or at least we've trained a whole cadre of non-mental health specialists in this treatment. I want to talk about the stakeholders who are involved in this group, because I would say that similar to our work in global mental health, they do form the foundation of this study. And I purposely put mothers and their families at the center of this of these circles, because similar to my work in global mental health, I can't imagine doing this work without the perspectives of mothers and their families informing what we do, correcting what we do, and ultimately scaling up what we do. Us researchers play sort of a side role. We're implementing this study, but really the foundation of this study, and I'm probably going to emphasize this more than once, are the mothers and families involved. Similarly, clinicians and a wide range of clinicians play an integral role to our study. So you saw that our site PIs represent an interdisciplinary group, but we have a wide range of clinicians, from obstetricians to psychiatrists to psychologists to nurses, to midwives, family practitioners, who play a really important role in informing the study. We have a few policymakers, but if there are any policymakers on the call today, do let me know if you're interested in Summit. We would love to incorporate you as part of our study team if there's good synergy, as we're looking to ultimately scale this up when we complete the study. The roles of stakeholders really vary depending on their expertise, but I would say they basically fall in informing 3-stage processes of this trial. So during development, individuals like Claire and Jamie Charlebois, who I think I saw on the list and who's on the call, who's a nurse practitioner, really inform the intervention content of our study. Is what we're delivering actually appropriate for our target population? And so, we had individuals review the manuals to see, is our intervention content relevant? Is it acceptable? Is it feasible? How should we go about selecting delivery agents or non-specialist providers? How should we recruit them? What would be the best way to excite people about this project? And very much talking about recruitment pathways from a patient-centered lens. And I should say that what we do, clearly, because we're funded by PCORI, but everything that we do does try to have a foundation of patient-centeredness. In terms of implementation, coming from a global mental health lens, diversity and equity is something that we are very focused on. I feel that so far we have managed to recruit 54% of our participants are non-white, and I think that's extremely important, particularly because of the access issue for ethnic minorities. And individuals like Claire and others have played a really important role in terms of how we can ensure that our populations are diverse from an ethnicity lens and other lenses as well. And again, ensuring that our intervention content remains centered, patient-centered. We have currently stopped our telemedicine session. We have currently stopped our in-person sessions, as you can imagine. Everyone who is being randomized, everyone who is consenting to the trial is only being randomized to the telemedicine arm. And so one of the ongoing conversations that we're having with many stakeholders in group and individual situations is how we should go about resuming in-person sessions. And that's a really important, it's such an important topic, not only to address the research question, but to ensure that, again, we're doing this from a patient-centered lens. There's been really interesting solutions that have come up with regards to how we can ensure the well-being and safety of our patients if we are to resume in-person sessions in the near or far future. Some of those solutions are site-specific, and some of them are solutions that we will be implementing. So hopefully I'm giving some examples of where stakeholders are involved in this study. And clearly in terms of dissemination, so we have so many different individuals who work and collaborate with so many different organizations. And so whether it is currently as we have this project up and running, or equally important, if not more important, when we do have our primary results, I'm sure our stakeholders will play a critical role in disseminating those results to their local, national, and international collaborators. And I want to end on this only because this is certainly, Nelson Mandela is certainly one of my heroes. But one of the things that I've learned the most through this journey of Summit, but also as a global mental health researcher, is the importance of context. It is easy as a researcher, as a clinical psychologist who has spent a lot of my life in school to forget the importance of context and language. And I read this quote, I think when I was first 17 or 18, and it stuck with me since. I think if we do more of this, and we continue to implement research from a patient-centered and stakeholder-focused lens, I think our research practices will only be better. I think our interventions will be better. And I think that there's a lot of potential to engage many of you in the kind of research that we do. So I'm going to hand it over to Claire to take it from here. So over to Claire.